So with that, I will give a brief introduction about Dr. Ben Park, who is my colleague and friend that we are really honored to have at our ICARE case conference, because Ben is now our Cancer Center director, which he took over for several months ago. Dr. Park is professor of medicine, breast medical oncologist. He developed and leads our molecular tumor boards at our cancer center. He's an international expert in liquid biopsies, and his research is dedicated to finding a cure for all types of breast cancer by investigating mutated and altered genes responsible for the development and progression of breast cancer, as well as genes that lead to drug resistance. So one other thing that Dr. Park does that we are very fortunate to have at Vanderbilt is he reviews every tumor test that comes out from our center. And, you know, us as genetics providers, he CCs us on anything that could be of germline significance. And again, he's one person, but we are very fortunate to have that level of engagement on the inherited cancer side. And again, many of the cases that I'll be discussing, Ben was directly responsible for bringing these cases to our attention. And then, you know, the patients were subsequently seen by our service. So with that, I will turn it over to Dr. Park.
Thanks for the generous introduction, Tua. I go by Ben, as everyone who knows me knows, and would really like to keep this informal. I'm trying to just I was told, a 15-minute introduction, so this really can't do justice to the explosion and the breadth and depth of tumor and germline testing that we actually do nowadays, particularly here at Vanderbilt. So thank you again for inviting me to talk. And I'd love to go over the cases and do some more in-depth questions afterwards. And I think particularly for this audience, a lot of this hopefully won't be so redundant, but apologies ahead of time if some of this is. And these are my disclosures. I looked at my slides from 2 years ago and they were really boring black and white, but I think in my effort to make this a little bit more splashy, some of the fonts get a little bit wonky, so I'll apologize. The overview of this very short talk is really about cancer as a genetic disease. And again, this audience is familiar with that, but really testing for now both germline and somatic variants. And though not as routine across medical centers, I really believe the importance of germline genetics in tumor testing. And I think that this audience, and particularly Dr. Powell, too, and I would agree on that. And we've really been partners from the very beginning since I landed here in September 2018. Both at her genetics kind of conferences, as well as our molecular tumor boards, where we attend one another's conferences on a pretty regular basis. I'm going to talk a little bit about precision oncology, again, specifically germline versus somatic DNA variants and clinical actionability. Actually, just a little bit about that, but then also the interpretation and what we're trying to address in our molecular tumor boards and why genetics and geneticists are so important to that mission. All right, so what is precision oncology? The way I look at that, this is really what Vanderbilt University Medical Center's moniker has been for the past few years, making healthcare personal. And when one thinks about it, that's really what precision oncology is, at least for me. It's making healthcare personal for every individual patient who has cancer. But that's kind of fighting an uphill battle because of how we've structured therapies and how we actually get data to actually give therapies for patients with cancer. And the current and past paradigm really is to treat all cancer patients the same based upon their tumor type, their stage, et cetera. And in my business of breast cancer, that's why most patients with a given stage and type of breast cancer in terms of the receptor gets treated very similarly. That said, I think every one of us knows that we're unique individuals because of our DNA, and ergo, the cancer is also going to be very different from person to person. And that's what I really want to focus on in precision oncology is what are the underpinnings or underlying DNA defects, mistakes, alterations, whatever you want to call it, that potentially drive that patient's cancer and that we can target. And so how do we go about that? Well, many in this audience probably also recognize that cancer is not just the result of one DNA mutation. One inherited mutation can predispose, but even in, for example, BRCA1 and 2 families, the cancer still has to accumulate multiple genetic alterations or hits, as we fondly call it, or often call it. And that's really pointed out in this diagram first proposed by Peter Knoll, and who was the discoverer of the CML Philadelphia chromosome, which we now know is the BCR-ABL translocation or fusion product. The idea is very simple. Normal cells in the green here on the left are normally proliferating. All it takes is one selective hit or DNA alteration that gives it a growth advantage, but also there has to be a clonal wave of expansion is the way it was put. That's necessary because when one thinks about it, you need statistically a lot of cells so that any one of those cells, which all have the first hit, can get the second hit. And then that one also has a wave of clonal expansion. So it's all about Darwinian evolution. Mistakes are happening all the time. Many of them are deleterious to the cell, so we'll never see that cell. But all it takes is one that gives it a growth advantage from all the surrounding neighbors, and then you're off to the races. To eventually to the point where if you get enough of these genetic hits, you turn into a full-blown cancer. So this concept really applies to what we're thinking about in germline genetics. When you think about a BRCA1 carrier, for example, every single cell in the body has a hit already. And so the likelihood that the target organs, in the case of BRCA1 and 2, ovaries and breast predominantly, are going to get a second hit is really, really high. And that's usually loss of the second wild type allele in that cell. Again, even that's not enough. Still need additional genetic hits in order to get a normal cell all the way to a full-blown cancer. All right, so the importance of germline testing has grown and grown. I think that you all lived and breathed this, and we certainly have seen an explosion of genetic testing as guidelines have been revised, as more companies have offered broader germline testing, and also I would say because of therapeutic actionability. So the classic examples using Sanger sequencing involved, the BRCA test from Myriad, just BRCA1 and 2 gene mutations, and that was it. And now with next-gen sequencing, that's really replaced the old standards. And panel gene testing, as familiar with this audience, has really become routine, where we're typically ordering anywhere from 10 to 80 or 90 even genes. When you think about the fact, though, that the human genome is 20,000 genes, that's still a relatively small fraction. And obviously the problem with that is that oftentimes we find VUSs and we don't know what to do with it. But I think germline testing is something that's just going to increase as we move forward in the cancer business. And there's challenges with that, although there are also opportunities. Probably the biggest opportunity in the last couple of years, or more than that, probably the last decade, is that we now have therapeutic actionability. In the old days, I would tell patients, well, this isn't really going to affect your therapies, but it will affect your blood relatives, the people that could have also inherited this mutant gene, or now it's called pathogenic variant. That's not true anymore. We have actionability in terms of therapies, and I think many in this audience already know this, but if you have a germline gene mutation or even somatic in BRCA1 and 2 genes, those cancers are very susceptible to PARP inhibitors. And so that's been now approved for ovarian cancers with some caveats now, breast cancers, prostate cancers, and pancreatic cancers. Mismatch repair genes, so these are the genes responsible in the germline for Lynch syndrome, as many of you know. These are often have such high tumor mutation burdens that they are going to be very responsive to immunotherapies, particularly anti-PD-1 pembrolizumab, but probably also anti-PD-L1 as well. And those are now, again, FDA-approved indications. There are probably others. We do know there is already, in fact, one for renal cell carcinoma with VHL germline mutations and belzutifan. I think that's how you pronounce it. And that's also being studied right now in the somatic VHL space, but it is actually an approved therapy right now for renal cell carcinomas with VHL germline mutations, again, pathogenic variants. I just always want to put this out because I think a lot of people know, and gosh, this is kind of small and I apologize for that, that how PARP inhibitors work. This was really championed by Alan Ashworth, who's now Cancer Center Director at UCSF. But when he was at the UK, he really helped discover the BRCA2 gene while he was at the Sanger Center. And the cool part about this, he did what we now know as an isogenic drug screen or synthetic lethal screen, looking at mouse BRCA1 knockout cells versus wild type, and put them through a drug screen and found PARP inhibitors. And the idea behind how this works is that our cells are always making mistakes or actually breaks in the DNA strands, double strand and single strand breaks. And if those breaks cannot be repaired, whether you're a cancer cell or a normal cell, the cell's going to die because you need that contiguous DNA in order to divide the DNA during mitosis and live. The normal cells, therefore, will have a redundant set of pathways, and there's probably more than this, but PARP is one of those pathways, and so is BRCA for homologous recombination pathway and then basic excision repair pathway, respectively. And those can fix these breaks. However, cells with BRCA mutations or BRCA mutations that are, this is the cancer cell, right? So that both alleles are functionally inactivated. They can't fix their DNA double-strand breaks with homologous recombination because they don't have a BRCA1 or 2 gene. However, they still rely upon and can use the PARP pathway. Now you use PARP inhibitors, and in the normal cells of that individual who's a carrier, they still have one good copy. So they have an intact HR pathway. You put PARP inhibitors, nothing happens, we hope, because there's still the capacity to repair that double-stranded DNA with a one good copy of BRCA1 or 2. On the other hand, in that same individual with a BRCA1 or 2 related cancer, now you put PARP inhibitor and you understand that this cell can no longer fix its double-stranded DNA breaks and therefore will undergo programmed cell death. So quite an elegant story. It's really a champion and an example of how basic science can quickly translate into meaningful clinical drugs. Now, getting to the testing, tumor-only testing is really something that has evolved over the past, probably 15 or 20 some years now at this point. In the past, these were super small gene panels. We used Sanger sequencing. There's only a few hotspot mutations that were tested because of time and cost. But with next-gen sequencing, this evolved into larger cancer gene panels with several hundred genes. Whole exome sequencing is actually feasible, but the time and the ability to actually use that information in a meaningful way hasn't made it the standard of care. That said, just like in germline testing, tumor testing, companies now are doing more and more whole exome sequencing, but just analyzing the cancer genes panels, if you will. And so reporting out just the ones that are on their list. With bigger panel of genes, what has happened to this field is that distinguishing somatic alterations becomes problematic. Now, the advantage of this is generally there's no consent required from the patient when doing these types of tumor-only testing. But the big disadvantage is that we don't know what is germline and what is not. And again, that has clinical implications or can have clinical implications. So for tumor-only testing, although there is utility for some mutations with approved therapies, and this may have changed, but in the old days, people would criticize what we did in the precision oncology space because they said, oh, look at this study that someone did comparing genomically driven care versus just standard of care, and there was often no difference. One has to remember those were kind of what we call basket-like trials where they were just throwing all different cancer types and putting them into little buckets based upon the mutations that they had. And when one thinks about that, that's kind of a doomed experiment because breast cancer, regardless of the mutation status, as a group is going to do way better than pancreas cancer. And yet here we are throwing them into the same trial kind of patient portfolio. So there were flawed studies to begin with. They're also mostly performed in metastatic disease. And so some of those were heavily pretreated. Most of these were heavily pretreated patients. So again, it's not the greatest study or data to really draw from. We actually did a study like that and showed the opposite. So it just goes to show you, it really just depends on what you're actually doing at your institution. Now, what's relatively new in the field of tumor sequencing is taking the germline sample, blood, cheeks, saliva, et cetera, and then using that as a filter for the tumor sequencing to figure out what is truly germline and what is actually somatic. So sequencing of both normal and tumor tissue allows for filtering out. There are advantages, the ones we obviously want, that we can see what is truly in the tumor. The disadvantages is that some of the algorithms and pipelines that people have used in the past, if they find a germline variant, they'll just wipe it out. And that is a missed opportunity. So this is something that really is important to know what's being tested and what is not being tested, and then what is being reported and what is not being reported. As an example, the company we use, Tempus, more recently decided if there was germline filtering and there were VUSs in the germline, they're no longer reporting those. And I think that was, well, I know this largely because clinicians got confused. Oncologists generally don't understand even the difference between somatic and germline variants. I know that may sound surprising, but Tua can back me up on this. And so that's where it's important to know what's being reported and what's not. So with germline filtering, the patients have to consent if they want to be told, or the physician wants to be told, of what is quote unquote, an incidental finding. So if they're not consented, then nothing's going to be reported in the germline. Some tumor-only tests now state possibility of germline variant. So as an example, Foundation Medicine, which does tumor-only without a germline control, if they see a BRCA1 mutation, they'll say this could be germline and in the appropriate context should be tested. And some companies will actually do some germline filtering and selectively unfilter variants and report that in an effort to kind of put on the antenna, hey, there's a BRCA1 variant, pathogenic variant here. It could be germline, you might want to check it out. So there's an example of this from a company that I was familiar with back in Baltimore. This is their disclaimer. This has probably evolved because this was several years ago, but they used to not do this. And I told them you're potentially missing BRCA1 and 2 and other germline variants. So they started putting this proviso that if there were, in fact, germline variants, they wouldn't say they were germline or not, but that they, for these 4 genes, they would basically tell you that there was something there. It's kind of a workaround. Again, I don't know what they do these days. Importantly, also, whenever one orders these tests and interprets it, need to understand what's being tested and what is not being tested. And a great example here was a colleague, again, back in my old institution, there was a head and neck tumor in the right buccal mucosa, and it has a 75% tumor purity, meaning roughly the pathologist guessed that 75% of the tissue is in fact cancerous. Now, look here at the source of normal DNA, which is saliva. You all probably are saying, what? You can't do that. And you're right, you can't, because the cancer cells and the cancer DNA are going to be in the saliva. And so using that as a source of normal DNA is probably not the best source. So these are things one really has to be careful in looking at. This is from the same company, but a colleague of mine who's a prostate cancer oncologist ordered a test on his patient. Tumor cellularity was pretty low on this, 20%, and source of normal DNA not provided. So most of these companies, including the one we use, you don't have to give a source of germline DNA, but you have to understand that if you get that test result back, it's a different set of circumstances. And so this particular physician came to me and said, Ben, look at this, there's an androgen receptor mutation. Should I use anti-androgen, like next line anti-androgen therapy? And my response was, well, probably not, because if you look at the mutant allele fraction, given the low tumor cellularity, this is being 100%, this is probably going to be germline. Sure enough, this is just a normal variant. On the other hand, this PIK3CA mutation is an activating one. It's not as common as some of the other ones. And its lowered mutant fraction also kind of spoke to the fact that this probably was actually in the tumor. But these are things that, again, present challenges to people who aren't familiar with genetics, variant allele fractions, et cetera. So along those lines, there are always these sets of questions. I'm not going to necessarily go through all of them, maybe just highlight some of them that we address all the time in our weekly tumor board. Is the mutation real? Is there missing information? This is a big one for both germline and tumor. Who should be tested and who should not? And I will tell you, I think this keeps expanding. For tumor testing, I have kind of basically said anyone who has incurable and or metastatic disease really should get tested, because those are patients who are at some point going to run out of options. We try to follow guidelines here about germline testing, but we also know there's so many more people who are eligible for this that we've had to think a little bit out of the box, and we're doing point of care testing now like many other centers. Big questions of what are drivers and what are passengers? When do you refer for genetic testing? Is there a druggable mutation, et cetera, et cetera? So these are all things that we discuss and have become increasingly important as we order more of these tests. The tests evolve in their platform. Some are using germline, some are not. Some are up to the provider, some are not. Very, very difficult questions to address sometimes. And this is why from the very beginning at both Hopkins and here, for our molecular tumor boards, we've always really welcomed, but really also need and almost mandate that we need genetic counselors, geneticists to really help us interpret a lot of the findings. The one we started here back in October of 2018 is our Vanderbilt Ingram Cancer Center Hereditary and Oncology Personalized Evaluation, or HOPE Molecular Tumor Board. We do also have an international one that meets once monthly, and I've partnered with various institutions, both within the United States and across the world, really. And this is actually not updated, I apologize. We have many more centers than this. These were the first kind of 7 or 8. We're probably up to 20 or maybe even 50 some institutions. A lot of community hospital sites have actually joined us as well. In fact, every time I give this ICARE, maybe once a year or once every 2 years, there's more interest. So if you do have interest, send me an email and we'll put you on our listserv, and you can present cases, you can listen in. whatever you want. It's usually the fourth Monday at 9 a.m. Central Time, of the fourth Monday of the month. And so in conclusion, hopefully I've given you the picture of that tumor testing and germline testing can in fact yield actionable variants, but great care must be used when interpreting these results. Knowing what is being tested, filtered, reported out is really, really important. Even, and I didn't mention so much here, is that really an actionable mutation? We get a lot of stuff where people say, and companies will say, oh, this is a mutation and it has a drug, but it ends up not being a real pathogenic variant with evidence from that. So establishing molecular tumor boards and really learning from this process can really help.
Hey, thank you, Ben. That was really great. I wanted to open it up for questions. And I had a couple of questions for you. Well, one comment. First of all, with our cancer genome, again, like Ben said, it is a great forum. So if any of you or oncologists that you work with are interested, this is something that Ben already hosts. So I think he would really welcome additional participants. It's something he's already doing. The other thing I wanted you to comment on, Ben, because it's a hot topic and maybe we'll get you back to talk about it in more depth, is liquid biopsy and its role in surveillance. Because I know, you're my go-to for questions with this, but I think our broader group would be interested in your thoughts.
Yeah, for sure. And again, apologies, I didn't have enough time to include that. And it really is its own topic, less so about germline stuff. So that's why I didn't actually highlight it. But liquid biopsies right now are predominantly so in case you don't know, they're most of the time nowadays when we're talking about liquid biopsy, it's cell-free DNA. So all of our cells shed naked, free-floating DNA into the circulation. We don't know if this has a purpose or function. Most of us just think, or I call it cellular poop, and it's just a waste product. But cancer cells will also do this. And so when we have a patient with cancer, and we've known about this forever, there should be, and there is, cancer cell-free DNA molecules. We call that circulating tumor DNA. The challenge with this is, since all the cells, normal and cancer, are secreting the cell-free DNA, even with a patient with a heavy metastatic burden, oftentimes has relatively very low amounts of ctDNA from the tumor relative to the total pool of cell-free DNA. And so the ability to extract and get the sensitivity for this used to be a huge challenge. With next-gen sequencing and various bioinformatics techniques, we can do this pretty routinely now. Commercially, this is still not as good or as sensitive, I should say, as a tumor-only test because, again, you just have a lot more cancer DNA to work with it with a biopsy of a tissue versus a blood draw where you're only getting few molecules of ctDNA. That, again, is something that is lost on a lot of people. So if they see a variant allele fraction that's, 1%, they think, oh, that can't be that important. But in fact, 1% on a liquid biopsy is pretty good. And it's all relative depending on the other variants that are reported of what the level of ctDNA is. The other aspect that's become increasingly challenging is as these tests have gotten better and more sensitive, now they're being moved into the early cancer stages and even pre-cancer stages, meaning that can we use these tests to predict, for example, for someone who has completed standard of care therapy with curative intent for breast cancer, we don't know who's cured and who's not. We know if they recur that they weren't cured, but we don't otherwise know. This is true for many solid tumor early stage cancer cases. What if we had these liquid biopsies that could pick up microscopic residual disease and say, oh, this patient isn't cured? Or if it's negative, are they cured? And then move that into the pre-screening cases like, hey, we should just get blood tests for the whole population. And if they're positive, then they have a cancer. So there's problems with this approach. I still think, I'm hopeful. I often use the thing Pandora's box. Pandora's box has been open, but I think that what people forget, the last thing that flies out of Pandora's box is hope. And so that's what I hang on to. And I think these things will work, but we're not ready for it yet. And companies are selling these things before we are. And what I mean by that is it's been true and proven the validation for the positive predictive value, meaning whether it's an early screen test or after curative intent cancer therapy, if you find a DNA mutation that in the blood, that probably does mean that they have some cancer cells floating around. But what we don't know is what do we do with that? And so studies are ongoing right now that if we treat just that cancer DNA and it goes away, does that mean we're curing more patients? Or in the pre-screening side, if we can actually detect it that much earlier and we actually detect something and treat it, do we actually get better outcomes? That's the difference between what we call clinical validation versus clinical utility. And unless there's utility, a tenet of medicine, everyone on this call probably knows this, don't order a test unless it actually changes your ability to do something. The negative predictive value right now is also a problem, meaning that if it's negative, it's not necessarily truly negative. And there's data on this. So that part is still a huge challenge. And what I and many other people are going for is that holy grail. I want to be able to draw a tube of blood from a patient and tell him or her, you know what, it's negative, you don't have cancer, or your chance of cancer is like less than 1% or less than 0.5%. We are far from there. And so stay tuned. We've got better technologies, better things coming down the pipeline, but we're just not there yet. And unfortunately, I've seen it already happen where someone gets a positive blood test, they get a CAT scan, there's nothing there. What do you do with that information? Nobody knows, and it creates a huge amount of anxiety. So that's my soapbox. I'll get off it now.
Yeah, and I guess main message as well is in the screening or surveillance setting, not ready for prime time or outside of the context of a clinical.
Correct. And because of this, they're not covered by insurance. So they're, charging thousands of dollars and people will get billed for this.
Yeah. So I have some comments in the chat, and then I have a question as well. So
okay.
One of the questions which Brenda already addressed was clarifying, do all oncologists order germline testing up front, then refer to genetics? And as Brenda already said, some are ordering, and I'll just be honest, the thing is, what we realize is people need this testing in order to guide care, right? So as genetics, we cannot be kind of the step, like the funnel to order all or, see all the patients, because we just don't have the staffing to be able to do that, which I think a lot of people are. So these patients need to be seen urgently. So we've developed a model where we will provide support. Katie Lang, who leads our service, has actually been working directly with the oncology team across various different service lines to be able to do that. So there is close communication, a lot of interface. So we're almost like the decision support people, but we are not necessarily the ones ordering the test. And, for the most part, does it work 100%? No, but nothing works 100%, but it's the best that we could do in order to address this like expanding and, exploding volume, because it keeps becoming more. We can't keep up with referrals, and I don't anticipate we're going to be able to. We're going to come up with innovative models. And what I'll say is, Ben, I don't even know if you know this yet, but Katie's been getting the e-consult service up and running.
Ah, cool.
We are starting to get e-consults, which is very exciting. And again, something where people can ask members of our service within the EHR for an opinion, provider to provider interface, and we just give some input. And Katie's been handling these just to work out the kinks. But again, I think that's another way that we'll be able to improve our throughput.
I also just want to give a shout out to you and the rest of the genetics team. We call it the Hereditary Cancer Clinic here, Brenda, Meredith, everyone. We couldn't do this if we didn't have reliable, thoughtful, and generous partners in genetics, because it really takes a team that is patient focused and understanding that, you know what, it's not ideal that they're not seeing the counselors first, but some of these patients can't wait for counseling and testing because they could get a PARP inhibitor if they're BRCA1 positive. And so I think that's what really has helped our patients, is that we are willing to work together and know that sometimes, perfect is the enemy of good enough. And I think Tu is exactly right. It's not perfect, but we have to do something.
It's a pragmatic approach, right? At the end of the day, you just need to get things done in order to meet our patient needs. And that is it's not going to be met by coming through our service, because we don't have the capacity. I'm going to, Holly Mears has had her hand up. Holly, you have a question to ask? Speaker is still.
Can she get unmuted, or does someone have to unmute her?
She is unmuted if she'd like to speak.
Yeah, no, she's not unmuted because I can see her on my screen. She's muted.
Yeah, she's able to talk if she unmutes her. her speaker.
She said it was an accident.
Oh,
Oh,
the
okay.
hand up was
All
the
right.
accident.
Okay, sorry about that. And then we have some other questions. What do you think about RNA sequencing or whole genome sequencing on tumors? Because whole exome sequencing has limitation on detecting fusion genes, which could be targetable.
Yeah, so it's a great question. Tempus, who is our vendor partner, does whole transcriptomic RNA sequencing. Now, there's some caveats to that. One, you need enough tumor tissue. And I saw somewhere, someone asked about tumor cellularity. What I mean by that is when you take a chunk of tissue for sequencing, the pathologist has to look at it and say, how much of this specimen is tumor cells and how much is normal cells? You always get some contaminating normal cells. And that factors into the equation when we're looking at, oh, how much of this represents the tumor DNA and how much of this represents the normal DNA. I will also tell you, pathologists will agree to disagree on cellularity percentages, where someone may call it 20%, another may call it 40%. So there is a wide variability in what one pathologist would call cellularity percentage and the other one. That said, with 30% cellularity at Tempus, they will also, as part of their test, do a complete RNA-seq analysis. We'll get gene expression, but they'll also do a fusion analysis. Now, that's also equally important to understand this. There are some companies, I'm not going to mention names, when they say they do this, they are only looking bioinformatically at the fusions of interest, and then they'll report them out. This is very akin to whole exome panel sequencing that I mentioned for both Germline now and tumor sequencing, where you can sequence the whole exome. There's a ton of data there, and doing the informatics and the analysis takes a lot of time. And you don't really need all that right now for cancer, at least. And so they'll only look at the 500 genes, analyze it, and look for mutations. The same is true for this RNA analysis. A lot of companies will only look for fusions that they're interested in. It's much faster that way, right? But what Tempus does is unbiased whole transcriptomic analysis. So they'll pull out every fusion in theory that they can find. And we've had some pretty amazing stories. They're not that common, but we've pulled out rare fusions that led to diagnoses, rare fusions that led to targeted therapies. So I'm a big fan of that. The other thing on the horizon right now, some companies are, and this is not Tempus, but some companies are actually now using RNA for liquid biopsies and even tissue biopsies to fill in whole exome sequencing. Meaning that if your tumor tissue is limiting, we have to remember, like, many of the genes of a tumor cell or cancer cells are going to be amping up the expression. So the RNA molecule per DNA molecule is way higher, orders of magnitude higher. What if you could use that data to fill in the DNA data so that you could cover the complete exome? So it's kind of an interesting way to combine RNA with DNA to fill in a whole exome, if that makes sense. If it doesn't make sense, I'm sorry.
No, that's fascinating. And I have another question, which I think a lot of people have this question in their minds, from Nicoletta. Will you offer germline testing for all somatic findings? Almost all tumors have TP53 and other common gene mutations. We cannot accommodate all of these in our small clinic. And I'm going to go a bit further. Ben, maybe you can speak to the ESMO guidelines as well, because they have a great chart in there, right? Where they have frequencies of, like, what is your yield potentially from.
Yeah. No, I think this is why I am an advocate for doing germline filtering, as we call it. And by the way, Tua has been, and her team has been very, very good about reminding me that this is not true germline testing. So when I order a test through Tempus, we get the tumor sent to them, we get hopefully a germline sample sent to them, and then they do the filtering. So to answer your point, Nicoletta, we're doing that already, because hopefully, again, there are some providers who don't want to get the germline because it requires consent, but 90% of our patients, or not more, when they get a tumor test, there's a accompanying germline, and Tempus takes the germline and compares it with the tumor. So we know right away whether it's somatic or germline, and we don't have to worry about offering for every TP53 mutation. Now, I will tell you, and Tua has seen this, part of what I do when I go through these reports, if there's no germline and there's a TP53 mutation that looks like it could be germline, and all the other VAFs are kind of in that or much lower range. Even on a liquid biopsy, you can pretty much tell, and Tua knows this too, if there's a 45 to 55% pathogenic variant and all the rest of them are at 1%, that's almost certainly going to be a germline pathogenic variant. Those are the ones I flag. I let the providers know. I CC Tua and everyone on the HCC who has agreed to be CC'd on it, and say, you might want to think about getting a germline test. I'm sorry, that didn't answer your question though, Tua. What were you saying about the ESMO guidelines?
Yeah, the ESMO guidelines, like say you're in a situation where you don't have the somatic, kind of like what you said. I do think that the ESMO guidelines may be helpful, right? Because there's certain ones that you see, and recognizing the importance of allele frequency,
Right.
that are more highly likely to be germline than others, just based on which gene it's in, right?
Yep. No, I think that's absolutely true. I still like the approach that we're doing right now is if we get the germline filtering up front and we find an incidental, we verify it with a real germline test. Fortunately, our partner offers that, and most of our patients don't pay extra for that at all. But I also think, and this is the hard part, and we're trying to automate this, as you know, Tua, but there's so many. Maybe as AI is getting smarter with like Chat GPT and stuff, that we'll finally have to talk. There's so many perturbations and things that don't fit into neat algorithms that I think it's really hard right now, which is why I'm still looking at these and flagging them and letting them know if this is potentially a germline finding. So guidelines are guidelines. I'm often fond of saying that, but they're not rules, policies, because they can't be. There's always going to be exceptions. And I think that looking at these, most of them are exceptions. As Tua knows, we've found tons of BRCA2 mutations in some lung cancers, and they're germline. It doesn't make sense to us. And
Well, beyond that, the other thing we found, really because Ben does this, is even with paired tumor germline, there are specific genes that are tested for that are reported out on germline, right? So just because you don't get a positive, we found cases where it looked germline, and then when you look, but like on the tumor test, germline was negative, and then we were able to figure out that, hey, it wasn't reported because it's not one of the lists, like one of the genes on their list for reporting. So
they try to follow the ACMG 59, was that it? And it's probably evolved by now. And that's part of the issue, was that by following that, even though there was a germline mutation, it just wasn't reported out. And so that's another great point of what I was trying to say earlier too, of how you have to know what's being tested, what was the analyte used or the tissue used, and then what's being reported.
Yeah,
It's
and Brenda,
very, very important. And we also had that recent other case, do you remember, Tua, where for the germline variant, it was considered a VUS, but from the pathogenic variant, it was considered, or the somatic variant considered pathogenic. Those are also difficult cases that we kind of try to adjudicate at the molecular tumor board.
Yeah, which is great that we have this forum, and that's what I would encourage others to have, similar types of forum where you can get the multidisciplinary input, because as Ben kind of said, all oncologists have varying levels of training in, germline interpretation. The other one, I know Sonia can attest to this, is for breast cancer cases, if you get a patient that is negative on the tumor, or like doesn't have a mutation on the tumor test, that doesn't mean that the germline is out of the question, because large rearrangements aren't tested for, right? So you still need the germline testing if you meet criteria, even if you're negative for tumor. And Brenda has put in the germline genes that are on the Tempus panel. We happen to use Tempus. We're certainly not saying that they're definitely not the only game in town, but it is what we are using at Vanderbilt. Do you know if there are any particular guidelines for somatic testing companies similar to ACMG regarding reporting of secondary findings? Ben, you would know this, but my understanding is no.
Yeah, that's right. There's not for tumor testing really even policies or suggestions rather than guidelines or even policies. And I think that that's one of the things that we've been working with Tempus and hopefully others, that there really should be. I think people do try to follow ACMG's kind of guidelines on reporting incidental findings if you find something like that. But,
Yeah, but it's ACMG plus, right?
Yeah.
Like a lot of these people, and we don't know what the rationale is. Some of the stuff they test for, I don't understand why they're reporting it out, but
yeah, I think Brianna, what you said at the last part of your text chat is exactly right. It seems like varying labs make varying decisions, and it's hard to keep track. And I think that gets back to what I was trying to make the main point of what I was talking about, is that you have to really understand what's being tested, or, you know, in terms of the genes, what the tissue is that's being tested, and then what's being reported and what's not being reported. And it is a moving target. Even within the same company, as I mentioned earlier, Tempus used to report out somatic VUSs, germline VUSs, but now they don't, because I think they got so much confusion and pushback from clinicians that said, I don't want this. I don't know what to do with it. My patients are freaking out. They see a BRCA2 VUS. And, you know, I get that. So it's hard. I want more data, but most of my colleagues don't want all that data.
yeah, I know we're at time. I just wanted like just some closing thoughts. You know, we've talked for a long time that tumor testing may end up being the segue into germline testing. And I think that's going to potentially happen, because down the road, I think we're all seeing a day where every cancer patient gets tumor sequencing, and there is going to be a lot of tumor results that we get that are potentially actionable and if confirmed in the germline. So this issue is certainly not going to go away. Well, thank you everyone for your attendance, and big thank you to Ben, as always. We really appreciate
Thank you.
insight and guidance.